Hello, fellow anesthesia providers. My name is Vincent Pereja, third year SRNA from UNCG. First of all, I would just like to thank you all for your participation in my project. I really appreciate it. To avoid keeping you all from your busy schedules, I'll try to keep this presentation concise. And today I will be presenting on an educational intervention. As the title suggests, the topic I will be discussing is the prevention of spinal-induced hypothermia in elective cesarean section patients. The purpose of my DMP project is to address the use of intraoperative multimodal active warming in preventing spinal-induced hypothermia in non-emergent C-sections. My three aims include, first, using current evidence-based practice to educate CRNAs on the latest methods in reducing the instances of spinal-induced hypothermia. Second, I want to identify the barriers to changes in practice. And last, I want to evaluate for reported reductions in the incidence of hypothermia, shivering, and maternal discomfort. Childbirth is a momentous event in a woman's life. The perception of the event is influenced by the process and outcomes experienced in the OR. So as anesthetic providers, we want patients to associate their elective C-sections in a positive way, which has been seen to lead to better physical and psychological outcomes. Due to evolving practices, public perception, and anxiety surrounding delivery, spinal anesthesia has been preferred compared to general anesthesia for elective C-sections. The two main drawbacks associated with spinal anesthesia include spinal-induced hypotension and my project's focus, which is spinal-induced hypothermia. So the physiology behind spinal anesthesia-induced hypothermia starts when the sympathectomy redistributes the body heat from central compartments to the periphery, resulting in hypothermia. Core temperatures can decrease by 0.06 degrees Celsius for each dermatome level blocked, and vasomotor tone is inhibited below that level through somatic neural and sympathetic blockade. Our physiological defenses, vasoconstriction and shivering, are blunted during the duration of the spinal anesthetic. Shivering threshold can be reduced by about 0.6 degrees Celsius. In addition, opioids, even morphine doses of 150 micrograms into the intrathecal space may also intensify hypothermia. Some deleterious effects of hypothermia include increased O2 consumption, blood loss, rate of infection, coagulopathy, increased rates of hospital stays, increased risk of myocardial ischemia, and also patient discomfort. And ultimately, our goal is to effectively prevent rather than reactively treat spinal-induced hypothermia. To address hypothermia, there are two active warming techniques available to us: forced air warming and intravenous fluid warming. So radiation is the highest contributor to heat loss in the OR. We all know this. To combat it, we use forced air warmers of differing varieties. We have upper body, lower body, and underbody. And typically, an upper body would suffice for abdominal surgeries, but in the fully aware patient, it's loud and it limits surface area for skin to skin. So the ideal goal is to cover as much surface area so we can decrease the core to peripheral temperature gradient. The other active warming technique is the use of intravenous fluid warmers. Studies have shown that IV fluid warming machines are superior to cabinet warmers. And on average, about 2 to 3 liters of crystalloid is infused during C-sections. Patients get hypothermic due to co-loading of crystalloids to decrease the instances of spinal-induced hypotension, hemodynamic shifts, and blood loss. Warming the patient from the inside will help narrow the core peripheral temperature gradient. The next 3 slides will cover patients and neonatal outcomes. In a double-blind RCT, multimodal active warming intraoperatively increased maternal temperatures on arrival to PACU. It also minimized perioperative temperature drops and decreased incidence of perioperative hypothermia, and also improved maternal thermal comfort scores compared to the control group. Although a majority of patients still got hypothermic, there was a 27% decrease in maternal hypothermia. Attributing factors to hypothermia that the researchers noted included the infusion of IV crystalloids under 300 millimeters of mercury pressure to attenuate maternal hypotension. So that could have compromised the outflow temperatures from the fluid warming devices that they were using. Another contributing factor could be the use of only a lower extremity forced air warmer. Some recommendations that they included was to avoid IV infusions of crystalloids under pressure to maintain output temperature flows from their IV fluid warmer, and also to increase the surface area covered by implementing an underbody warmer instead of a lower body warmer. The next 3 studies not only showed the effectiveness of multimodal active warming intraoperatively, but also the importance of collaborating with perioperative staff to help prevent maternal hypothermia post-spinal anesthesia. Pre-warming the patient from 30 to 60 minutes preoperatively, in addition to multimodal active warming intraoperatively, yielded significant differences in temperature between intervention and control groups in the preoperative phase, lowest Foley core temperatures, intraoperative hypothermia, and recovery room temperatures. It was interesting to note that in the prospective RCT, an increased incidence of hypothermia was noted when there was a gap of greater than 20 minutes between leaving the preoperative area to the OR for spinal anesthetic. Some recommendations from these studies include decreasing that gap time between the preoperative area and initiating spinal in the OR to under 20 minutes, and initiating forced air warming in pre-op as well, and continuing throughout the intraoperative phase. With regards to neonatal outcomes, multimodal active warming interventions have not led to significant differences. Some studies have seen an increase in newborn umbilical artery blood pH when mothers are actively warmed, but the physiological mechanisms are still unknown. The popular theory is that when maternal blood pH decreases due to hypothermia, the neonatal umbilical artery blood pH should also decrease as well. But to keep it short, further research is needed on the impact of multimodal active warming neonatal outcomes. Current literature mostly focuses more on the maternal outcomes compared to neonates. To summarize, multimodal intraoperative active warming techniques are safe and effective in blunting the incidence of spinal-induced hypothermia in elective C-sections. Mothers have reduced incidence of hypothermia, reduced incidence of shivering, increased maternal comfort, and increased childbirthing experiences, which is something that they always want. And that's all I have for you today. In 1 month, you will receive a link to complete a follow-up survey to assess for your utilization of intraoperative multimodal active warming, perceived barriers to utilization, and to evaluate self-reported efficacy in patient outcomes. I just want to thank you all so much for hanging around. If you have questions, my contact info is in the email that you received. Thank you guys so much.